So good afternoon. I'll be basically talking about the differences between a government versus a private medical college as far as teaching and infrastructure go. I think some differences are very obvious to all of us. The clinical work, the clinical exposure is obviously a lot more in a government hospital simply because the patient load is high, whereas in a private medical college, because of the expenses for the patient, the load tends to be a little less, but I think that's changing now because of insurance coming into play. Even a lot of the private institutes rather than medical colleges, a lot of private institutes do get a good enough clinical load. Now, why I think I will be able to kind of get a balance between the both of them is because I was trained at a government medical college throughout my medicine, my post-graduation, even my fellowship was all at a government center, but right now I'm working at a private institute, so I know the differences in the training, I know the differences in the teaching, and I know the differences also in the infrastructure. I have no financial disclosures, but I wish I did have, because I think medical education has become a very lucrative thing with the number of medical colleges that are coming up, day in and day out. It's obviously a very lucrative business. So, is there the teaching comparable in government and private medical colleges? I think it's not comparable, but there seems to be a balance somewhere in between. Why this is important is nearly 900 ophthalmologists are trained in India every year. This is by a paper by Dr. GP003 some time back. I'm sure the numbers have increased now by at least 30 to 40%. And finally, at the end of the day, we want to know if our residents are happy. So, I am basically going to be using an article that was published sometime in IGO about what the residents want, and then do a comparative between a private and a government institute. So, if you look at the satisfaction of places across the world, in Canada and Brazil and the US, the residents are pretty much happy with whatever the training that they get. But this is a very interesting article by Ajay K. and Dr. Krishna Prasad, and they published this in IGO in 2015, where they've done an excellent survey of ophthalmological training in Karnataka and southern India in the present status. They say that less than 20% of people are satisfied. There are some who are very satisfied, but a large number are not satisfied or just give a grading of fair. So, now that we know that we don't actually stand in a very good position, we need to understand the crowd, we need to understand why they are pursuing ophthalmology, whether and how, whether they just got it because they got a seat in the entrance exam, because they want surgical exposure. And of course, in ophthalmology, the workload is quite predictable. You don't get too many emergencies, or maybe they had a very good exposure during the undergraduation. They trained under somebody so good during undergraduation, that's why they went in. Or family influence, ophthalmologist family, they have no option but to go into ophthalmology. Or now probably even the earning potential is fairly good with ophthalmology. So, what is the need of the hour? This is what we asked these postgraduates, and they said initially it has to start off with an orientation program. They need to know what is there in the new course. They need to have some expectations from what they can get through their degree. It should be a good guidance from them, and you can also actually at this point of time screen residents for stereo vision and dexterity, because we've seen some of our fellows who have actually come in for phaco-refractive fellowship who don't have good stereo vision at all. So it's really scary how they're going to operate future on their patients. Also, what are the surgical training that they're going to get, and what are the diagnostic instruments that are there in the institute itself, which can probably help in the training. This generally does not happen in most government medical colleges. You just enter the medical college, and then you go straight into your residency. As far as the teaching module goes, resident doctors are not actually very fond of didactic lectures when actually one person is standing at the end of the stage like this and there are 10 people listening. They want it to be a little more interactive, and this is very common in private medical schools because they have a very structured program. But at the same time, they have more audiovisual aids, they have three-dimensional computer animation technology where they teach people. But if it is a very complex topic, then there is no option but to have these didactic lectures. In government medical college, we see a lot of bedside teaching, and I think case presentation is the most popular form when we ask residents what they like. They like being taught history taking so that they don't miss out important points. What are the examination methods on the patient? There's no other better way to learn it like that. What are the investigations in that particular patient you'd like to order, and what is the management? So when you're having this discussion at the bedside, it's something else, because 10 people will have 10 different doubts and you can all learn it as a group. This is the norm mostly in government medical colleges, and I think we learn a lot more this way as bedside clinics. But having said that, in private medical colleges, they don't have enough clinical exposure. So it may not always be possible when you have one patient with one particular condition walking into your OPD and there are 20 residents examining. It's not going to go down very well with the patient. So obviously not that. So this platform like the All India Ophthalmic Society or even the state societies play a very large role in bridging this deficiency by conducting several CMEs and wet lab training. Even now, Dr. Deepak is conducting the SSTC, which is hugely popular because there are some techniques that are never taught in some institutes, and they're coming here and learning it live, so it's something else. As far as the resources go, obviously private medical colleges are better funded, so they have access to a lot of instruments. We have fellows coming in for training who are not even well versed with indirect. Forget any of the higher advanced. In fact, right now we had a fellow who couldn't even diagnose an RD. She said macular edema. So now what we do even for antra-segment fellows is send them for a rotation to learn indirect ophthalmoscopy, which probably access is limited in probably a government center. Library they have e-journal provisions, and they can better interpret a lot of investigations with ease because they have so much exposure. But the downside is that these residents start to rely on investigations rather than actually developing clinical skills, and that also becomes very difficult because you keep ordering investigations from the patients. So he who studies medicine without books sails an uncharted sea, but he who studies medicine without patients does not go to the sea at all. You're going to be so not confident examining a patient or treating a patient if you don't have hands-on experience. So this is much better in government medical colleges. They can actually independently handle cases within the first year itself. And most of these professors are old timers. They prefer the old school of teaching where they want you to know this sign, that sign. You know how it is when we cleared our post-graduation. And also most of the time they don't get to refer here. The minute we see something, one small pseudo-exfoliation, we write glaucoma opinion. You see pressures a little over 20, you say glaucoma opinion. That's not really true in a medical college. You have to learn to manage your patients as a whole. So obviously you're learning better. And wet lab, there are many of them. Again, this is seen most in private institutes. Government medical colleges don't tend to have this. So there is a lot of unsupervised training also in some centers. So if you have something like this, it does help. And of course, again at AIOC, we have the wet lab happening every year, which is extremely helpful for beginners. And instead of going directly into the operation theatre where it's very stressful, teaching sessions cannot be predicted or repeated, and the required skill may be above or below the resident's abilities, wet labs are the way to go. One last thing, in this time on age of litigation and medico-legal, I think informed consents tend to get missed out in a very busy practice, especially in a government center. I think from the level of post-graduation, the importance of informed consent should be driven in, because you never know when you're going to get into trouble. Research and training, just one last slide. Research and training we have seen is a very important component. If we didn't have research and training, we won't be having a conference of this size. Your number of postgraduates and the fellows who are presenting is unbelievably high. And also at the end of the day, publishing, though most of these colleges do have a structure for dissertation, most of the postgraduates feel that the support that they need in the form of statistics or even the research question is lacking. So that again can probably be helped by having an central agency which will help these people. And with the Medical Council of India making it mandatory to have publications, it becomes all the more important in medical colleges that you learn to publish. Last but not the least, surgical training. They feel that the lack of infrastructure in government medical colleges, they don't learn advanced surgeries, which is not exactly true. With the number of surgical load that they get, it's quite good. And mostly in ophthalmology, I think the main focus is on cataract surgery. They felt that non-cataract surgery, they're not doing well enough. So these are the last few things that they had problems with, that they felt that they needed non-clinical skills and how to handle a patient, how to handle stress of starting a new practice. This again is probably something that can be covered at both ends. Thank you so much.